There's one or two particular drugs that have a very high risk of weight gain that you don't want to give to a patient who maybe has diabetes or is already overweight, and you're worried that it will, further their own clinical picture. So I want you to be aware of side effects, especially major ones that we've discussed, agranulocytosis, right? So those kinds of themes. I'm not going to ask you what dose to give a patient, but you should be aware that with steroids we like to taper, right? We like to taper off. I'm not going to ask you how quickly, because that's really subjective. So it's not going to be, this patient has this problem, what drug are you going to give them? I'm not going to ask those types of questions. Like, I'm not going to ask you to diagnose. I'm not going to ask you to do any of that kind of clinical stuff. Yeah.
Do you have a lot of pathophysiology? Because
you mean the review that I did of the physiology stuff?
Yeah. For thyroid, there's
no, the questions are really about the drugs.
Okay, cool.
Yeah, but again, remember, with thyroid hormone, a lot of its pharmacology is the physiology of thyroid hormones in the body, right?
Okay, cool.
Yeah, so, the thioamides, you have to kind of know the biosynthesis of thyroid hormones to be able to know how its mechanism of action actually works, right?
Okay.
So this is supposed to build a bit on what you guys learned last semester. And I know that wasn't the smoothest of semesters for you guys. I'm aware of that. And that's why I did a lot of review, really.
Okay.
So hopefully it was helpful
to
have those diagrams. Yeah. Yeah, and it was good for me because I haven't studied this stuff in 24 years. I just give drugs left and right. I don't know what drug to give you. I don't know why I'm giving it to them. Okay, let's start. Okay, so we have these two out, okay?
That's funny.
I want you guys to get really comfortable with how to read these kinds of tables. These tables scared me when I was a medical student. I'm sure they scare you too. You're just like, what the hell is this? So again, one is antidepressant doses. Again, don't memorize, okay? You're going to get a lot of experience in your clinical rotations about what dose to take, what dose to prescribe a patient, when, et cetera, et cetera. Again, I'm looking for trends. When you're going to start an elderly patient on an antidepressant, you're going to usually start lower than you would with a young, healthy patient, right? So I want you to be aware of those kinds of trends, and why would we do that? Why would you start an older patient, 85-year-old who's been... Because of side effects. One of them being EPS. That was antidepressant, right? It's with... Everybody knows first generation. First, yeah, good. That's really why we found second generation antipsychotics, right? But because of the EPS. It's such a huge thing to know. So again, being aware that the typical antipsychotics cause EPS, right? As one of the big things in this group of drugs, it's really important to be aware for the exam and for clinical practice.
The antidepressants, right? That's one.
Yeah, so we're looking at antidepressants. Yeah.
Okay.
So again, what I'm saying is, don't know that you start citalopram at 20 milligrams usually, right? But you're going to learn that, right? But one thing you may want to know is, why is fluvoxamine so much higher of a starting dose than the others, right? Things like that. So let's get into these. So as I'm talking, if you glance over if you need me to slow down, let me know. If you want to stop to kind of compare it to the tables, let me know. I will do that kind of periodically throughout the lecture. Okay. I'm on the right lecture. Okay, good. Has anybody been reading the medical letter articles or not really? You be honest, seriously. Not okay. It's 2. Okay. I don't think I included the medical letter articles with the psychosis. Yeah, I really like that a lot. One other thing that I've been listening to recently is the Curbsiders. Have you guys heard of that podcast? It's amazing. So it's done by 3 internal medicine physicians. I don't know, from somewhere in the East Coast, and they review primary care topics every week. And they did one a few weeks ago about geriatric depression that was really fascinating. And they always talk about medication.
Curbsiders.
Curbsiders. Has somebody here heard of it?
No, I'm just repeating.
Yeah, curbside. So, you know, like curbside specialist or whatever.
That's
where
awesome.
the little name comes from. Yeah, and it's free. You can find it on those podcast apps, or if you have an iPhone on the iTunes, whatever. Yeah. I have a Pixel phone. I like my Pixel. Okay.
She's smart. She's smart.
Okay, so I put in an outline. So antidepressants, I really want you to think of them broadly. First generation, second generation. Our first generation are TCAs. Does anybody know what TCA stands for?
Tricyclic.
Tricyclic antidepressants and MAOIs. Does anybody know what that is?
Monoxidase. Inhibitors.
Inhibitors, good, yeah. Whenever you see that little I, think inhibitor. Why do you think we try to find second generation antidepressants? Because of the side effects. So the first two are very powerful antidepressants. Okay? And I don't remember the exact story. I had read somewhere that I don't remember why they were developing these chemicals, but they just happened to notice that one of the TCAs or MAOIs worked on patients who had depression. And then they're like, oh, let's try it for that. And then they realized afterwards, like, oh my gosh, look at the laundry list of side effects these guys have because of their mechanisms of action, right? We're going to try to tie those things in together. Second generation, we have SSRIs, which hopefully most of you guys have heard of as a group of drugs. They're very commonly used. I think the third most commonly used drugs are antidepressant SSRIs in particular. I prescribed quite a few. SNRIs, NDRIs, which really the big one that we should know there is bupropion, and then the atypical antidepressants, and we'll talk a little bit about both trazodone and mirtazapine. But the first generation is going to give you a good idea of mechanism of action and how mechanism of action ties into side effects as much as we can figure out to date, meaning like, research-wise. And then that will also help you understand the side effects of the second generation. So I will spend some time on first generation, even though we don't use them as much anymore clinically for depression. They're not our first line. Okay, so before we get into it, any questions on just basic neuroanatomy, neurons, all that stuff? You guys are good. Yeah. If I say neurons, axons, neuroglia, all that stuff sounds good. Okay. Neurotransmitters. Did you guys review neurotransmitters? A little bit? Yeah. Kind of? Okay, so we'll review a little bit quickly. I'll go through them really quickly, okay? So let's start. So glutamate, it's the most abundant neurotransmitter that we have in the body. It's probably 90% of the synaptic connections in the brain involve this neurotransmitter. So it's a really important one to know just in general. It doesn't have a huge role in antidepressants. But just being aware. I put a lot of information about the receptors and things like that. Any questions? I don't want to spend too much time on that. But if you have questions, we can talk about it. GABA and glycine, these really are our biggest inhibitory neurotransmitters. So glutamate is an excitatory neurotransmitter, right? It's involved in learning and memory, really broadly. Whereas GABA and glycine are more inhibitory neurotransmitters. GABA, we'll see have a bigger role in the next lecture, which we'll be talking about seizures and how to treat seizures. But GABA is really important for relaxation, decreasing your muscle tension, slowing your breathing rate, etc. Glycine is also, yes?
So GABA is always more suppressive than, right? Do your own thing.
You mean like is it like fight or flight versus rest and digest? Mm-hmm. Yeah. So I would think of it really as, let's leave it for the seizure lecture, because I think it'll make more sense here. I'd rather we focus on dopamine and serotonin and those neurotransmitters for today, because they're going to have a really huge role. Acetylcholine. So acetylcholine is maybe you're thinking of acetylcholine, which has a huge role in which autonomic
parasympathetic.
Parasympathetic. Okay. So acetylcholine we'll talk a little bit about today with respect to antidepressants. So it has a role in both the central and the peripheral nervous system, right? Hopefully this is like a little recall here. Central, it's involved mostly with what? Like broad picture. So what kind of functions is it involved in centrally? Like what's the, what's its role for?
Rest of
Learning, yes. Memory. Nobody has acetylcholine right now. Attention span. Okay, so peripheral nervous system, we said it's involved in mostly the parasympathetic, rest, digest, right? Rest and digest. Okay, dopamine. Dopamine has a ton of different functions. So I listed a bunch of them there: drive, reward, psychosis. It's like everything under the sun. Inhibition of prolactin. It has a bunch of different pathways that dopamine works through. We'll get into it a little bit when we talk about the drugs that affect dopamine. And then there are dopamine receptors. D1 through D5 are the ones that we typically talk about with respect to psych drugs. And then norepinephrine. Where's norepinephrine made? Yes, and it's also made in the brain. Okay, so there's two places where norepinephrine comes from. It also has central and peripheral role. So in the peripheral nervous system, what's its major role? The sympathetic, yes, exactly, fight and flight. And then centrally, it's also involved in increasing arousal and alertness and helping with memory and focusing attention. So I should be giving you shots of norepinephrine right now. Okay. So you run away from me. Okay. Serotonin is going to be a huge one that we talk about in the antidepressants. It has tons of different receptors. Serotonin is usually referred to as 5-HT. Again, hopefully this is nothing new. And then there's a number, I don't know, 1 through 5 or something, that is when we're talking about the receptors. It's going to be 5-HT2 that we're going to talk about a lot in this class. That's the particular receptor that these drugs work on. Also implicated in attention as well as behavior, thermoregulation. Serotonin also has interesting role in the body outside of the nervous system or outside of the brain and central nervous system. Does anybody know what kinds of roles it has? The gut. Yeah, actually the majority of serotonin is found in the gut, right? So it does have a role in the GI tract. We think it drives motility. Drugs that affect serotonin seem to decrease nausea. What's a big drug that affects nausea? That works centrally? Zofran, yeah. It blocks serotonin. And then it can also be involved in constriction of arterioles. So histamine. We tend to forget that histamine is also a neurotransmitter. We think of it in allergies and all that stuff, but it's actually also a neurotransmitter, and it does modulate arousal and attention, as well as feeding behaviors. So a lot of these drugs are antihistaminic, and we think that's why they tend to cause weight gain. So it's a theory. So antihistamines, there are first generation and second generation antihistamines. Have you guys covered that at all yet, or not yet? Not yet, a little bit, maybe. So first generation work centrally as well as peripherally, and that's why they make you drowsy, right? The second generation only work peripherally, and that's why they do not make you drowsy. Second generation are the ones that maybe many of you guys have been on. Claritin is a big one. Okay. So I put up here a schematic of kind of where the drugs can work. I'm not going to get into it. I think it's really self-explanatory, but it's there just to review if you need it. And then I put some definitions about agonists, antagonists. Is this a pretty clear slide to everybody? Okay, you guys have gone through this. Looks like a lot. Okay. Downregulation, upregulation. Have you guys heard of those terms? Yes. Okay, good. So the biggest takeaway from this slide is that in psychiatry, we really tend to go low and slow because of the side effect profile of these drugs. This is a huge takeaway from this lecture when you go into psych, is especially in the primary care world, maybe people are a little more ruthless in the psych world, but in the primary care world where, we're worrying about drug-drug interactions, what side effects is this patient going to experience, because you'll never know, you just won't know what the patient will say in terms of how they're feeling once they start these drugs. So many times with antidepressants antipsychotics, which I have rarely prescribed antipsychotics by myself. In residency, I did under the supervision of an attending, but in primary care, very rarely did I start a patient on antipsychotics. They're big guns, so they're not easy drugs, and they require a lot of careful monitoring. And it's not something that I had a lot of practice with. And we'll talk about why EPS is a big one, right, with side effects. But with antidepressants, a lot of patients, I would start them at a quarter of the dose before I bump them up to a full dose, right? And for most patients, I could easily bump them up really quickly to a full dose within a matter of 2-3 weeks. Other patients, it would take weeks, if not months, to do that. So, okay. So let's talk about depression. Let's talk about indications first. So we think of antidepressants as just for depression, but they're not. So anxiety is actually the #2 reason we use antidepressants. And for a lot of the SSRIs, we use them at a little bit of a lower dose for anxiety, again, increasing the dose as needed. But anxiety is the #2 reason why we use this group of drugs. And anxiety can include things like PTSD, post-traumatic stress disorder, OCD, obsessive compulsive disorder, generalized anxiety. We can use some of these drugs for pain, different pain disorders like fibromyalgia, premenstrual dysphoric disorder, which is probably called something else now, but this is like your PMS, right? Your classic PMS symptoms. Smoking cessation, bupropion can be used for smoking cessation. Eating disorders. Enuresis is another one. Why do you think we can use these drugs for enuresis? Which neurotransmitter?
Because it blocks.
Acetylcholine, yeah. TCAs, we've even used them in children who have enuresis. And then what is vasomotor symptoms of menopause? What does that refer to? Okay, what's that? Hot flashes, night sweats, insomnia, mood swings, right? So antidepressants can have a lot of different indications. So really, I listed out kind of what major depression is in the DSM. Have you guys heard of the DSM? Okay. Not going to get into it. Again, like I mentioned, I'm not going to be testing you guys on what are the symptoms of depression. That's another class. But it's there just so you know, especially when we talk about energy, concentration, appetite, right? These are all symptoms. The changes in these things are all symptoms of depression. What's the most important symptom to ask about, though, depression?
Suicide.
Suicide, yeah. Is suicide. You guys know how to ask about suicide? Yeah.
Thought about hurting yourself, hurting others?
Yeah, so sometimes suicidal ideation, that term may be difficult to understand, but do you have any thoughts of hurting yourself or hurting anybody else? And do you have any plans, right? So in residency, I had patients who were suicidal, but not in like clinical practice. I have had people who have had thoughts of it, but have never acted on those thoughts or actually gone further and made plans. We are in a suicide epidemic. You guys know this right now, right, within the U.S., and it hits at all ages. So whether you're talking about older patients or younger patients, it hits everybody, unfortunately. Do you guys know kind of what the most common ways people commit suicide? Drug overdose, which tends to be more female patients. What's the other more common way? Guns. Yeah. So you always gotta ask about guns, or guns in the home. And I have had patients who have died from guns, and I have had patients who have died from overdose. I remember one very clear, actually most patients who commit suicide or complete it have seen a healthcare provider within the past 2 weeks before the action happened, whether they went to hospital, urgent care, their primary care office, whatever it is, they see some kind of healthcare provider. And it's like a huge percentage of people who either commit suicide or complete suicide that have seen healthcare providers. So when I hear that, you really kind of feel the weight, right? So always ask about it. Never be afraid to ask a patient or hesitate. And once you start, it'll get easier. It can be a really difficult question to ask. Like we have our own fears, right, about kind of asking this question. Because what if they like clam up or close up? But most patients will actually really appreciate that you ask them the question. They'll feel like, oh, okay, this person really cares. Okay, so in terms of treatment, so obviously the goal is to get to complete remission. That can be really difficult. A lot of patients go through multiple drugs, a before they find something that seems to work for them. A lot of patients need therapy and drugs. Actually, all of my patients who have depression, I always offer them therapy. That's number one. I feel like therapy can do a lot more good sometimes than the drugs. But our goal is complete remission. You always want to tell patients before they start antidepressant that they will not feel immediately better, right? They will feel somewhat better within the coming week or two, but the full effect of the drug can take 4 to 8 weeks. And if you start a patient on a lower dose, then it could take 8 to 12 weeks, right, for it to really kick in. Most of these drugs, they're going to be on them for a year before you either maybe go down or start tapering off the drug and eventually stop it. And again, we don't have great drugs for depression because we really don't understand depression from like a biology standpoint. You know, as well as a lot of these drugs, we don't fully understand the mechanisms of action, unfortunately. So response rates can be quite low sometimes in certain groups. Okay, let's talk about the drugs. Enough. Okay, so TCAs. So TCAs were first line from 50s to the 80s. So I don't know, I just wonder what it was like to be a psychiatrist in the 70s and the 80s when you had like so much crazy side effects going on with these drugs. They really became less popular after the second generations came up in terms of their chemical structures. So there's two major groups. There's tertiary amines and there's secondary amines. So the tertiary amines have two methyl groups. So amitriptyline and imipramine in the picture on the slide, right, are tertiary amines. The N with the two lines coming down are the two methyl groups. The secondary amines have one methyl group. Nortriptyline and dicypramine are the ones that are shown there. And both of those, the secondary amines, dicypramine and nortriptyline, are the active metabolites of imipramine and amitriptyline. Okay, and there's also a tetracyclic, which I've never seen used in the US. Okay. So let's talk about their mechanism of action. There's quite a bit. Let's see, do we want to? So as we're talking about mechanism of action, pull up your side effects of antidepressant medications. I know the way it's kind of copied is annoying, but you may want to just on the back side write down the subject headings of each column. So anticholinergic. So if you guys want to write it down, I'll read them off right now. Okay, so obviously your first column is your drug, right? So anticholinergic, so anti-ACH, then drowsiness, insomnia/agitation, the third side effect column. Orthostatic hypotension, which receptor is that? Alpha receptor, good. QTC prolongation. So these drugs have effects on the receptors on the heart. GI toxicity. Weight gain. And then sexual dysfunction is the last column. Okay. So just glancing at the chart, right? Which group of drugs has the most pluses in all of these columns? TCAs, right? And the MAOIs as well, right? Maybe not as high as some of the TCAs, but I mean across the board, there's pluses in all of them. You guys see that? How the TCAs and the MAOIs are the worst when it comes to side effects? And then if you look at the top, the SSRIs, besides sexual dysfunction, right, the rest of them are like a 0 to 1 plus, maybe 2 in some. So this is why we use SSRIs so much more commonly and they're considered first line now. Okay?
The highest number is up to 4.
Yeah, I believe so. Yeah.
4 means like highest number.
4 plus means high. So they have a scale, 0 is none and 4 is high. 1 is slightly, 2 is low, 3 is moderate, and 4 is high. And the scale's on the back, below the table. And if you guys have you will get up-to-date access, I think, right? Or no? Clinical year, yeah. It's a great, we use it all the time. I love up-to-date. Makes my life so easy. Okay. So transmitters. So mechanism of action. What transmitters are TCAs working on? Serotonin. What else? What else? What's that? I heard a few things. Not really. Dopamine is probably the one that doesn't. What's that? Acetylcholine. What else? Histamine. Yes. So you can see it's like working on all the neurotransmitters, right? That's why its side effects are all over the place. So it's going to inhibit reuptake of serotonin and norepinephrine. Okay? It's going to inhibit sodium, calcium, and potassium channels, especially in the heart, which is why it can cause QTC prolongation, arrhythmias, and really why TCAs in overdose can be lethal compared to other antidepressants. It's going to antagonize acetylcholine and histamine, as well as the alpha receptors, which is why it has all these different side effects. Unfortunately, the side effects can happen quickly once the patient starts the drug, whereas the therapeutic effect takes time for it to actually start. So you have to prep patients that this may happen. Okay. So again, we said there's a really broad spectrum of their side effects. So let's get into their side effects. One takeaway from here is that the tertiary tricyclics generally cause more side effects compared to the secondary. Why that is, I don't know. It maybe has to do with their chemical structure. But they in particular tend to cause more anticholinergic side effects and are more sedating. Okay, so let's talk about their side effects. So the antidepressant effect comes from the inhibiting the reuptake of serotonin and norepinephrine. The sexual dysfunction also comes from inhibiting 5-HT reuptake as well. Sexual dysfunction tends to be a major symptom in SSRIs because they selectively do that kind of a mechanism, whereas TCAs are not just working on 5-HT, and that's not their most powerful mechanism of action. So sexual dysfunction is common in some of them, but a lot of them, I don't know, we don't really have adequate data on it, and you're not going to see sexual dysfunction being a major problem that patients will report while on TCAs, okay? So cardiac, we talked about that a little bit. So their blockade of alpha receptors are going to cause the orthostatic hypotension that you can see. So if you're starting a patient on a TCA and they're on blood pressure medications, what are you going to want to tell them?
Blood pressure might may drop.
Yeah, you may get dizzy. You may start to feel a little woozy in the head when you change positions too quickly, right? So, be on the lookout for this. And you may want to even lower their blood pressure medications, right? If you're starting them on a TCA. Because it affects the other channels like sodium channels, potassium, it can cause arrhythmias, it can cause a reduced heart rate, conduction problems. So I'm giving you kind of these details, but in general, cardiac problems are a big deal with TCAs. And you're really not going to give a patient who has heart disease a TCA, is the bottom line. They can lower the seizure threshold. We'll talk a lot more about seizures, like I said, in about 2 weeks. Anti-muscarinic or anticholinergic, anti-ACH. What are the symptoms you're going to feel if you have anticholinergic side effects? Dry mouth, dry eyes, urinary retention, which is why we can use these for enuresis, right? What else? Constipation. Constipation is a big one, actually. So these are the most common side effects that patients who are on TCAs will feel. So that gives you an indication that probably its anticholinergic mechanism of action is a powerful one, right? The antihistaminic effect will cause what? Drowsiness. What else? Sedation. What else? So we said histamine is also involved in like kind of your feeding. Yes, it can cause weight gain. We kind of theorize that it can increase appetite and cause weight gain. And then TCA overdose, this is a take-home message. You should know this for the boards. Usually they ask about this. So TCAs can be life-threatening and overdose. And we remembered it with the 3 C's, coma, cardiotoxicity, and convulsions, because of their effect on the ion channels. The treatment for it is sodium bicarb, usually. But it's that cardiotoxicity, that cardiac effect. That's the reason why the TCAs can be so lethal in overdose. Okay, so we talked about that. Okay. So we talked a lot about indications already, so I'm not going to talk about that. I mentioned the enuresis. And then the other big thing is chronic pain. So we do use amitriptyline and nortriptyline for chronic pain in patients. Okay, in terms of its pharmacokinetics, so TCAs are generally absorbed pretty rapidly and completely. They undergo first pass metabolism, about 50% of the drug. They bind to protein once they're in serum, and only their free fraction is the active portion of the drug. They're also really highly lipophilic. So what does that tell you?
Crosses the blood-brain barrier.
Yeah, they get everywhere in the body. They go everywhere. They're largely metabolized and eliminated by the liver. And the theme of today's talk is drug-drug interactions. I don't expect you guys to know which drugs may interact with which drugs, but just be aware whenever you prescribe a psychiatric medication, please always check the drug list. Up to date, and there's probably Hippocrates, and they all have these drug interaction, I don't know what they're called, where you basically enter in the drugs that a patient is on. EMRs do this like flawlessly. They're really good. A little red screen popping up saying, hey, your patient is on these drugs. Check and make sure that it's okay to prescribe. So I think it's pointless to memorize drug-drug interactions unless you prescribe so much and you know if this drug will interact with that drug at that point. But I mean, we have computers that can do this for us, or little books that you can carry in your pocket. But just know that drug-drug interactions are a huge deal with TCAs. If it's given with like decongestants, right, which are over the counter, they can increase the sympathomimetic activity in the body. Because these drugs tend to be metabolized by the cytochrome P450 system, again, a lot of drugs can increase TCA levels. And what are you worried about if TCA levels go up? You're worried about toxicity, right? Cardiotoxicity, exactly. And then we'll talk about serotonin syndrome, but drugs that increase serotonin in the body can cause serotonin syndrome, which can also be lethal. So MAOIs are particularly important in that, in serotonin syndrome. I've never ever seen a case of serotonin syndrome. But giving an MAOI and a TCA is a big no-no. So MAOIs, you never ever want to give another serotonin drug with an MAOI because of the serotonin syndrome risk. And actually, I think I put a little story in the notes about so as in residency we had work hour restrictions of 80 hours a week. That came about because an overworked intern, gave a patient 2 serotonergic drugs, and it ended up in that patient dying. And so they thought, this overworked intern, made this mistake, and so they cut back residency work hours to 80 hours a week. Not that most places follow that, but yeah, most places do follow it, except for surgery. Okay, so MAOIs, let's talk about those. So what are monoamine oxidases?
They bring down norepinephrine.
Yes, they bring down neurotransmitters. They inactivate them, right? They basically prevent the accumulation of these neurotransmitters in the presynaptic nerve terminals. They also function in the GI tract as well. So, has anybody heard of tyramine?
Yeah.
Yes, okay, good. So they also make sure that we don't absorb too much tyramine into our body from our gut, from our GI tract. There's two major forms of this enzyme, A and B, and I listed where they're mostly found in the body. A is mostly in the liver and the GI tract, and B is both are found in the central nervous system, and then A is primarily found outside in the liver and the GI tract. And A and B work on different neurotransmitters. Both work on dopamine and tyramine. A works also on serotonin and norepinephrine. Okay. So monoamine oxidase inhibitors, so they inhibit this enzyme, okay? So I think monoamine oxidase inhibitors came before TCAs, 1952, and TCAs were 1958. So these were probably the first chemical structures where they realized, oh, these guys have an effect on patients who have psychiatric illnesses. But they also had a whole host of other problems that came along with them, right? Okay, so in terms of its mechanism of action, they're going to inhibit the MAO enzymes, and they're basically going to bind irreversibly to these enzymes. What does that tell you? Yeah, once they stop the drug, what happens?
There's still until
They're still going to have that effect until the body makes new enzyme. Right. So the drug will last after a patient has stopped it. The antidepressant effect correlates with roughly about greater than 80% of this enzyme being inhibited. It takes 3 to 8 weeks before you see some kind of therapeutic onset happening. And then, like we said, you can see clinical effects for weeks after the drug is stopped. And I listed that it could take up to 40 days to regain 100% activity of the enzyme. They are among the most effective antidepressants, but you will see why we don't use them anymore. Okay, so again, they have really severe side effects. I listed a bunch of them here, but on your table, so let's flip to the back. So, not as crazy as TCAs, but across the board, right, you see a plus in most columns, except for which one? And why do you think they're not affecting QTC prolongation?
There's none of the enzymes on the heart.
Exactly, they're not the enzyme, but the, sorry, I didn't hear what you said.
There's none of the monochrome.
Yeah, the enzymes are not involved in the heart, but what are these guys not involved in to not cause heart? The channels, the ion channels, right? So they have no effect on ion channels. So such, you're not going to see QTC prolongation. Okay. But they can cause orthostatic hypotension, right? Because they are affecting the alpha receptor. Okay. So I wanted to talk about MAOIs. So hopefully, because we talked about TCAs and their side effects, MAOIs and their side effects make sense, right? So I'm not going to go into their side effects besides that. But what I do want to talk about is what used to be called the cheese reaction. So whenever you put a person on an MAOI, you gave them a list of foods that they couldn't eat. And those foods generally contain tyramine. Yeah. And what kind of foods contain tyramine?
Like
aged cheese.
Yes. Aged cheese, fermented foods, beans, certain meats, right? Tyramine is a sympathomimetic, and like we said, it's usually metabolized in the GI tract. If you block these enzymes, then you allow more tyramine to get into the bloodstream. If you have more tyramine and an MAOI on board, then a patient can end up having what's called serotonin syndrome or a hypertensive crisis. What's a hypertensive crisis?
Above 180.
Yeah.
Systolic.
Yeah, so it's not just the number though. What are you worried about in hypertensive
Symptoms,
crisis? Exactly. Yes. Exactly. Yeah. So anytime you have a patient with high blood pressure, you're going to get a UA urinalysis, right? You're going to get an EKG, right? So you're going to be thinking about these end organ damages, if you've heard this term. But in high blood pressure, you can see an effect, not always. Some patients walk around with 180 blood pressure and they're okay, right? So those patients, you're just going to start them on blood pressure medication and have them come back in a few days to see how they're doing quickly, right? But other patients, you may need to send them to an urgent care emergency room if you're in a primary care setting.
What's the time frame to get them out of that state?
You mean how quickly do you want to get their blood pressure down?
Yeah, hypertension, before damage starts to occur.
You want to get it down immediately. So in the emergency room, they will use, what's that?
Was it like within 2 hours? I thought that's what
I don't know if there's a hard and fast, maybe you guys may have learned a hard and fast rule in cardiology, but just from like residency and working in the hospital, as quick as you can. I mean, you put them on a heart monitor, right? And you're monitoring their blood pressure every few, nurses will monitor every few minutes. And then you kind of want to bring them down as quickly as possible within a matter of hours, I'd say. Yeah. I don't know if they were given 2 hours as a cutoff or something. I don't know where the 2 hours comes from. Maybe somebody can explain to me where 2 hours comes from.
I thought it was in the cardioelectric compartment.
Yeah, it was.
To bring them down within
Yeah, it
2
was
hours?
a hypertensive crisis. You have to bring them down with. That's a.
Yeah, I would say that most of the time they're going to come down faster than 2 hours. Yeah. Okay. Yeah, so hypertensive crisis is not just high blood pressure, but also the symptoms of end organ damage, or close to it. So let's talk about serotonin syndrome, though. Okay, so serotonin syndrome. So they can have altered mental status. They can be feverish or have a fever, tachycardic, ataxic. What does ataxic mean? And they're not really able to walk. They don't have coordination, diaphoresis, which is sweating, shivering, GI symptoms, right? So again, it's like the whole body. So they're kind of in not very specific symptoms. They're severe symptoms, right? But I mean, a lot of things can cause this. So that's why knowing what a patient is on is really critical, right? Knowing their drug list. So if they're on a serotonin drug, this is something that would be on your mind if you were to see a patient that you're thinking of sending to the ICU because they have this going on. So we talked about why MAOIs and other serotonergic drugs shouldn't be given while a patient is on an MAOI, and really for up to 2 weeks after an MAOI is stopped, right? Because it takes the body time to reproduce those enzymes after the MAOI drug is stopped. So you can still have a patient experience serotonin syndrome if they're given a serotonergic drug after they've stopped taking an MAOI. Does that make sense? Yep, okay. And I listed a few other drugs to watch out for. I also gave you guys a list of drugs that can precipitate serotonin syndrome. Do not memorize this for my class, but just so you know, I mean, it's a long list, right? But most of the big groups are groups of drugs, SSRIs, SNRIs, TCAs, and really what's a nice thing about this graph is the first column, the mechanism. So you can increase serotonin formation, or you can increase the release of serotonin, right? So this kind of takes you back to how the physiology of the body. So it's nice to kind of just review that. I will not test you on which drugs, but I do want you to know what, in terms of the psych drugs, I do want you to know which drugs can cause serotonin syndrome, MAOI being a big one. Okay. Okay, we have maybe 20 more slides. We'll get through them quickly. Okay. We'll take a break. Okay, let's talk about SSRIs. Unfortunately, SSRIs, they don't really have like prefix or something that groups, they kind of do a little bit, but you just have to know these drugs are all SSRIs. There's not a lot of them, but I would know them because they are so commonly prescribed. And they're so commonly prescribed because they're so easy to use. So you can think about TCAs and MAOIs doing all these crazy things, and then now you have a drug that really in comparison doesn't do very much and is tolerated by most people quite well. Okay, So 1987 is, I think, when we developed the first SSRI, and since then more have come out. There isn't one SSRI that's more effective than any other. So what does that tell you about this as a group of drugs? How are you going to choose these drugs for your patients?
Cheapest?
Price.
Price is hopefully not going to be the biggest thing, but it's going to be side effects, yeah. So sometimes you'll have a side effect that's a desirable side effect for a patient, right? And so you'll choose it based on that. So for example, like some of the SSRIs, we call them clean. What that means is their drug-drug interactions are lower than other drugs. They metabolize a lot kind of cleaner in the body. They don't have, effects that you wouldn't be as worried giving them to a patient who maybe is on a list of other drugs. So I'll highlight some of those for you guys. Their mechanism of action. So they're highly lipophilic. So we talked about highly lipophilic drugs crossing the blood-brain barrier. They inhibit serotonin reuptake transporters, like TCAs, right, on the presynaptic neurons. So they increase serotonin in the synaptic cleft. They have really weak affinity for other types of receptors, and I'm talking here primarily about norepinephrine and dopamine. So really you want to think about these as really affecting serotonin, and hence the name selective serotonin reuptake inhibitors, SSRIs, right? So their mechanism of action is built into their name, which is really nice. I think we should have done that for all drugs. Okay. The only one that I would be aware of is paroxetine. It weakly antagonizes cholinergic receptors. So let's see on our little chart here. So look on your side effect chart. So which one has anticholinergic effects? Paroxetine, and the rest don't, right? So you know that paroxetine, has some effect on ACH receptors, okay? And then I listed a little point about how there may be more to the mechanism of action because, we know that inhibition of reuptake does start immediately, but then the therapeutic effect really comes weeks later. So there may be more to this story than we're aware of in terms of how SSRIs work. But as of now, we don't really know. So that's a kind of a question mark. Okay. So these drugs are very well absorbed from the GI tract. They reach peak plasma levels in a matter of hours. Food does not affect their absorption, which is great, right? Because if you have a patient who is going through depression, what's their appetite going to be like? Yeah, it could be low, it could be high, it could be up and down. They may feel like they want to eat now and not, the next day. So, except with sertraline, it is enhanced by food. They do bind to proteins and they distribute widely throughout the body because of their lipophilic characteristics. Again, like the other psych drugs, metabolized and eliminated in the liver. And their elimination half-life for most of them is within 20 to 30 hours, except for the ones that I listed. So most of these drugs are going to be daily dosing drugs, basically. And then again, in terms of drug-drug interactions, citalopram, really S-citalopram and sertraline are the two go-to drugs in patients who are on other medications. It's going to be E-citalopram and sertraline because their drug-drug interactions are so much lower than the other psych drugs. Okay, so I listed kind of their dosing, which is there just for reference. Takeaway from here is a lot of times, like I mentioned before, you'll start at a low dose. So let's take sertraline. In some patients, I'll start them at 12.5 milligrams, right? Equal potent dose. So a therapeutic dose starts at 50 based on kind of what we know about this drug. And I start at 12.5. In a week, I'll up it to 25 if they're doing okay. And then maybe 2-3 weeks down the line, I'll up it to 50. In a patient who I kind of want to go low and slow. And other patients, if they're young, healthy, I'll start at 25, and in a week, I'll increase it to 50. So you'll see that kind of a practice happening with the dosages of these drugs. Okay, so in terms of their side effects, so the biggest takeaways here are going to be GI side effects. Those tend to come on early, and they usually improve. So if a patient sticks with the drug, the GI side effects should go away. Sexual dysfunction, which is the #1 reason why people stop these drugs. We don't know why they cause sexual dysfunction. It's not entirely clear. Weight gain, especially paroxetine. So let's look at our side effects. So you see weight gain in terms of paroxetine is the highest out of all of them, right? They're all kind of 1+, but paroxetine is the highest. And paroxetine also is the highest in terms of sexual dysfunction. So is paroxetine going to be your go-to SSRI in most patients? Probably not. Yeah. A QT prolongation has been reported in the literature. I've never seen it. And again, don't know why. So you can see in the side effects 0 to 1+ or 1+. I've never seen it. I've read about it. That's it. So it's not something that I would be really concerned about in patients, even patients who have heart disease. Again, takes about 4 to 8 weeks to reach their maximal efficacy. So the next few slides, I talk a little bit more detail about each drug. Let me see what kind of the biggest takeaways here are. So paroxetine, we mentioned that it's more anticholinergic than others. So I would be aware of that. And in general has worse side effect profile than the others. And that's because it's more rapidly absorbed. And so it's really more potent initially. And that's why people report more side effects with it. It's also a drug that you don't want to stop abruptly. In general, you don't want to stop any drug abruptly, especially if they're on a high dose, right? You're going to lower the dose slowly and then stop it. But paroxetine especially. And that's because the withdrawal from paroxetine can be a lot harder than some of the other ones. Citalopram and escitalopram are enantiomers of each other. What I would take away from here is that escitalopram is probably what we call the cleanest SSRI. It's the most tolerated one out of all of them. It's unfortunately an expensive one, but if you're able to prescribe it, especially for patients who are on other medications, an elderly patient, it's kind of the good one to go to. Okay, let's talk a little bit about withdrawal. So again, like I said, you never stop these drugs abruptly. You have to taper them off. And more so with the ones that have a shorter half-life. Withdrawal symptoms. What do you think are some of the symptoms that a patient would experience if they're withdrawing?
Shaking. Sweating.
Yeah. So they can be nervous, anxious. What's that?
Oh, sorry, I just said constipation.
Constipation. I don't know. Not sure. They'll have bouts of being tearful, crying. They can be dizzy, lightheaded. So a whole host of symptoms, right? So again, these can all be avoided by just slowly tapering off. And like I mentioned, paroxetine is the one with the most severe withdrawal symptoms. Okay. SNRIs. Okay. SNRIs. Why do you think SNRIs are not really first line? What does the name tell you about its mechanism of action? So what does that tell you about its side effects profile? It's going to have more side effects. Exactly, right? So again, they're good drugs. They work for a good number of patients, but for most patients, you will go to SSRIs first because they are more selective. They're working really on one neurotransmitter. So these block both serotonin, norepinephrine. I listed kind of how they vary in their affinity. Again, just kind of being aware of that. I'm not going to test you on which one's stronger than the other. So, like I mentioned, they may be more efficacious than SSRIs, but in most of the trials that have looked at SNRIs versus SSRIs, it hasn't been a huge advantage to make them first line. Plus the greater side effect profile, you're going to go to SSRIs first. So let's look at our side effect charts. Let's compare. So you can see SSRIs are the first group and then SNRIs are the second, right? So SNRIs are going to have more GI toxicity. They're going to have they're going to have more insomnia. That's interesting to me. So on here, it looks like SSRIs are better. I did not look at this. Right? Their SNRIs on here look better than their SSRIs. Yeah. Yeah, that's weird. I don't know what. Let's look. So SNRIs can produce anticholinergic-like effects, which appear to be mediated by noradrenergic effects on the autonomic nervous system, such as dry mouth, constipation. Okay. So that's why they didn't include it. I got it. I know why they did. So even though they don't work on ACH, because they're working on norepinephrine, they can cause pseudo anticholinergic side effects. So I would put that as a note in your chart so you remember, right? That even though they're not working on anticholinergic system, they're actually causing anticholinergic-like symptoms because they have a effect on norepinephrine, right? So they're stimulating norepinephrine receptors in the sympathetic nervous system, and that decreases parasympathetic tone, right? You guys are following me? That can cause this pseudo anticholinergic side effect. So even though, so this graph is telling you is including its mechanism of action with what the side effect is. So it's not a true anticholinergic side effect, it's a pseudo anticholinergic side effect. Does that make sense? Yeah. So what I would do if I was studying is I would make a big note right there, like in red, saying this is really why we don't use SNRIs as first line because of this, because of that reason. Because it can be misleading. Okay, but who reads the small font?
It says like
Yes, yeah, I did see that, yeah. And then it should be used with caution in narrow angle glaucoma and so on the back, before before the italicized text, the last line is one little line. So yeah, so let's see if is there anything else in there that we should notice.
something about dose-related increases in blood pressure. Are they just you have to monitor blood pressure regularly more in SNRIs?
Then SSRIs, okay. So it's in SNRIs, yeah. Yeah, so the first one is telling you the risk of QT prolongation in people who have comorbid conditions, right? The SS and SNRIs are associated with GI discomfort. Okay. Yeah, and then SNRs, I see your point. May cause persistent dose-related increases in blood pressure, primarily diastolic and heart rate, right? So, you know, maybe where it has orthostatic hypotension, QTC prolongation, you can just, since that's kind of the cardiac, two cardiac columns, you could maybe write a little note there referring to that footnote that says that they can cause persistent dose-related increases in blood pressure, right? So we're not talking about lowering of blood pressure, but they can primarily increase diastolic blood pressure and heart rate. So two reasons why, even though this chart is a little deceiving, you think SNRIs are better than SSRIs as drugs, but they're not. And it's in the footnotes as to why they're not. So me personally, I never read footnotes, which is bad. So I would make a note of those 2 points. So, okay, so it's good that we're going through this as we're talking about the lecture. Okay, and then, right, the SNRIs don't really have much an effect on, so alpha receptors, cholinergic, we talked about the cholinergic point, they have a pseudo anticholinergic effect, dopamine or histamine, right? So not really. Okay.
I have a question for the serotonin syndrome. Is it any antipsychotic, any two that you
Any two that affect serotonin. Yeah. So if you look on this little chart here that I gave you, so it has listed SSRIs, SNRIs, the serotonin modulators, dopamine, norepinephrine reuptake inhibitors, bupropion, which we'll talk about. TCAs, right? Yeah, so, okay. About SNRIs, what do we want to talk about with pharmacokinetics and dynamics? So food can decrease their rate of absorption, not their degree, so it just takes longer for them to get absorbed. But giving it with food can also reduce the nausea, which is both the SSRIs and SNRIs, that's a really common side effect, nausea and GI, upset stomach. So most of the SNRIs are not that protein bound. Duloxetine is highly protein bound. Most of them are renally excreted in an unchanged active form. Most of them require dose adjustment in the context of renal disease. Duloxetine is the one that's kind of the opposite of all of that. It's more highly protein bound and it's metabolized and excreted more by the liver. So again, drug-drug interactions, duloxetine is going to be the one that you're most concerned about, right? Whereas the other ones you're going to be more concerned about renal disease. So that's again something you may want to add to this, or if you're making your own chart. Okay. I put here just kind of their indications, which we've talked about. We talked about their side effects. These guys can also have discontinuation syndrome, withdrawal symptoms, and they tend to be more severe with venlafaxine and desvenlafaxine, which have a shorter half-life. So that's also something that I would be aware of as well. These you're going to taper off like you would with SSRIs, right? You're not going to abruptly stop them. Okay. Can you guys take 5 more slides? Yeah? Okay. So atypical antidepressants, I kind of grouped the rest of them under atypicals. Bupropion and mirtazapine are really the two that I would know, and those are the ones that I focus on here. So bupropion, also known as Wellbutrin, or Zyban, if you've heard of Wellbutrin. They inhibit dopamine reuptake much more than they do it inhibits dopamine reuptake much more than norepinephrine. It's hepatically metabolized. It's used as an adjunct to SSRIs. What does that mean?
Like together?
Yes. Yeah. So sometimes you'll max out an SSRI and the patient's like, I still don't feel right. You can add bupropion sometimes. It's also used in tobacco cessation, in smoking cessation. And seasonal affective disorder. So it has kind of these interesting indications besides just depression. Doesn't have significant serotonergic side effects, right? So it's not going to be, you're not going to see the sexual dysfunction with bupropion like you would with an SSRI. So if somebody has that as a side effect and they stop the SSRI, maybe you'll try bupropion. The main takeaway that I highlighted, I bolded there, is anxiety. So a patient who has depression with a component of anxiety to it, are you going to use this drug? No, right? So bupropion kind of makes people a little bit more hyper. And so it may be good in somebody who really is more down, who's their energy levels are really low, they're sleeping a lot. Maybe bupropion will help kind of wake them up a little bit. So, you kind of want to think about when this anxiety type side effect may actually be of benefit to a patient when you prescribe bupropion. And then mirtazapine. So let's talk about that because that has some interesting side effects. Has anybody seen Remeron being used? Mm-hmm. Where did you see it being used?
It was in a family medicine.
Do you remember what the story was or why they used it? Because it has interesting uses outside of depression.
Oh no, it was because the lady, she came in and like had those organs of hearing voices. So she had a
I've never seen it being used for psychosis. Interesting. Okay. So I have seen Remeron is an easy drug to take. I've actually seen it being used in patients who have cancer. So, and older patients as an appetite stimulant. Has anybody ever seen it being used as an appetite stimulant? Yeah. And to stimulate weight gain. So let's talk about why that happens. So it antagonizes alpha-2 receptors. It also blocks postsynaptic serotonin receptors, and it blocks histamine receptors, right? The weight gain. It undergoes liver metabolism, but it has few drug-drug interactions, which is why it's commonly used in geriatrics. It doesn't have, it's not as crazy of a drug in terms of its interactions with other drugs, in comparison to other psych drugs. And it also makes it a favorable option to use as an adjunct to antidepressants as well, or to augment them, especially if you want to sedate a patient, if you want to help their sleep, right? So if you want to help a patient with their appetite and their sleep, this is a great drug to consider. Okay. Serotonin modulators, nifazodone, trazodone, vilazodone, and vortioxetine. Okay, let's see. So these guys are antagonists of 5-HT2A receptors, and that will basically lead to their antidepressant effect. They're also weak inhibitors of the serotonin reuptake transport. They can also antagonize alpha-1 receptors, which, what do we worry about with alpha-1 receptors being antagonized? Orthostatic hypotension. They're moderately antagonize histamine receptors, so you worry about sedation, which may be a good thing, right, in some patients if you want to help them sleep. Okay. And the interesting thing about these drugs and why they're called modulators is they both antagonize serotonin and they inhibit its reuptake. So again, because sometimes the drugs, their mechanisms of action are so complicated, you don't always know what the side effects will be in some patients. But for the majority of serotonin modulators, drowsiness, orthostatic hypotension are going to be your two things. Really interesting side effect that's obviously not great is priapism. Does anybody know what that is?
Erection without
That can last hours, and they need to go to the emergency room for it. Okay. So anytime you put a patient on on any of these drugs, you want to have them be aware of that.
So like if they're on Viagra, don't prescribe this.
Or prescribe this and not Viagra.
2 words, 1 step.
Okay, so they can be used as a sleeping aid, right? Antidepressant. They can be used as an adjunct to SSRIs. It's a great sleep aid in patients who have depression, basically, is the takeaway. Okay, just 1 or 2 more slides, I think, and then we're done. Suicidality. So this is an interesting point to be aware of. So all of these drugs have an FDA black box warning that they increase the risk of suicidal thinking and behavior, especially in those under the age of 25, compared to placebo. So this is kind of weird, right? Like, what the heck? Yeah. So the takeaway I would take from this is you always need to ask about suicide before, during, after you initiate treatment, okay? So every visit, any patient that I'm treating them for depression, anxiety, any kind of psych illness, anything, you always ask about suicide. The studies haven't shown that they actually complete suicide, but it may increase the thoughts of suicide. And I don't know, is it because, you know, when you first start a drug, maybe there's a hope that this will work, but it doesn't work right away? Who knows? I mean, nobody really knows why that is. Yes?
I would think when you start the drug, you start to feel better, and then you have the energy to carry on to try on suicide.
Yeah.
Okay.
And you know, so actually the side effects, right? So maybe increased energy, the appetite, some of these things, the symptoms of depression come back, but the mood, the effect on mood doesn't happen until later on. So it's a great thought.
Yeah, so then what you do as a healthcare provider where you're kind of stuck with like the person.
So I wouldn't assume, because of this black box warning, don't like choose to not prescribe.
No, I was gonna ask a general question. This
Yeah,
is not-
okay, not this.
This is not necessarily like everyone's therapy.
Got it,
But
okay.
like, how does that put a provider where it's like, the patient's depressed and, well, not all the time, but it can lead to thinking about killing themselves, but then you're gonna put them on this,
If they're
it doesn't
depressed, they've
affect
probably
them.
already thought about it.
So, but do you get what I'm trying to say, like regardless?
Yeah, do you
the
feel like
outcome,
this
if
puts
it's
you
the
in a
same,
hard place?
Yeah, it puts you in a hard
Yeah,
place.
between a
because
rock and a
you're
hard
still
place.
gonna think about
Yeah, and so again, so I would never ever not prescribe a drug because of this black box warning, is what I'm saying, right? Basically, what the big takeaway for me from this is to always ask about suicide. And then if a patient says, yes, I've had thoughts about it, then you go to the next question. Well, what are those thoughts, right? You have a plan. Yeah, I thought about it. Do you have a firearm at home? What method have you thought of to harm yourself or to harm someone else, right? Or to kill yourself? So you go down that line. And at any point during all that questioning, you can ask for help. You can call somebody. You can call your local emergency room and be like, hey, I have a patient who, if you don't know what to do, you can always call and find out what to do. So some patients, they may have had thoughts, and that's it. And so then I talk to them about treatment, right? And I say, okay, look, depression, there's basically two main groups of treatments. There's drugs and there's therapy. And then we get into those, what are you interested in? A lot of my patients, I always, with all of my patients, I give them the option of both. Especially if their depression is, pretty severe. If it's mild depression, I rarely push the drug. I haven't seen it work that well yet. What's that?
Oh, yeah, that's a good question.
I didn't answer your question?
You did.
Oh, you did? Okay. And then,
So is any of this drug a prepared drug for postpartum depression?
so you're going to want to pick one that isn't going to, I have to look it up which one, but, so you have postpartum blues, right? And blues, most of the time, we're not going to treat with an SSRI. But if I've had a patient who, say, has had a history of depression, right, in the past, and then they get postpartum blues, I may have that conversation with them about whether they would want to start a drug or not again. And in terms of which drug, you'd have to look and see, so are they nursing or not, right? That's going to be a big question. And I think that's going to be the biggest question, is the nursing. Which one may go into breast milk? Yeah. In terms of one being more efficacious than the other, I don't know if we have that kind of data on postpartum blues, unless somebody has read about it and can tell
I
me.
was thinking more along the lines of the breastfeeding part, like which one
Yeah.
is safe. Because I know like many people have a postpartum blues, but like
Yes, it's really
the
cool.
postpartum depression is a possibility, or just safety in terms of
Yes.
preference because of lactation is what I was saying.
Yes, yeah, and I think at that point it's a really case-by-case basis, right? So is this blues, is this depression, and then how severe of a depression is it, right? So we hear of crazy cases of, new moms who neglect the baby because they can't take, I don't want to say neglect, that's a bad word, but they can't take care of their babies effectively because of the mood that they've been in. Postpartum blues are really interesting because a lot of it is due to the fluctuations in hormones, right, that are happening after pregnancy. So they're super common to get postpartum blues. I mean, I think anybody who's had a child has experienced some form of postpartum blues, I have too. And it's really common. And for the vast majority of them, they won't need medications, but therapy and making sure that they have some kind of support system in place, I think, is going to help with the vast majority of those cases. So, unfortunately, we do a great job of prenatal care in the US, but I don't feel like we do a great job of postnatal care, which is supporting moms who want to nurse or supporting moms who don't want to nurse, right? We kind of push breastfeeding on everybody. And there are some people who don't want to breastfeed, and that's okay. There's nothing wrong with that. So really, we have to find ways to support moms more, and I think that will take care of blues, and then, or will help alleviate some of the severity of blues. But then if you're really worried about depression, which I'm going to be worried about that in a patient who has a history of any kind of psychiatric conditions before they were pregnant or even during their pregnancy, family history of anything related to psych. Those are going to be patients that I'm going to want to keep a more careful eye on and maybe start medications earlier. In terms of which one, I've never prescribed an antidepressant in a postpartum patient. I just look it up. I look it up and see which one. I'm sure Up to Date and other, good clinical sites have good articles on how to treat postpartum depression with which SSRIs and stuff like that. But it's going to be an SSRI probably is my guess. Yeah. It's a great question. It's a really good question. Okay, mania. This is the last point. We'll get into mania and what it is after the break a little bit. But just know that antidepressants can induce mania. And most often it's in patients who we diagnose with depression but really have bipolar disorder. And bipolar disorder can be really hard to diagnose. We think it's depression because most patients who have bipolar disorder, bipolar is where you kind of fluctuate between mania and depression. Most of the time is spent in the depressed phase. And so a lot of these patients get diagnosed with depression, unipolar depression, instead of bipolar disorder, okay? Really the only way to kind of screen for this is to ask about family history and to ask about symptoms of mania. And we'll get a little bit into it in the next lecture, but I think you guys have psych, right? No?
Next semester.
Next semester, so you will get into these. Depression, schizophrenia, bipolar. You will know them inside out. These are the big diseases in psychiatry. Psychiatry is such a fascinating field. I find it to be. But so really, you're going to want to screen these patients, family history, and then symptoms of mania. Which hypomania it can manifest as somebody who's like super successful in their work, right? They don't really sleep that much and they're just like constantly active, and whatnot. So it can be really tricky to do. And so when you get your psych lecture, ask them about hypomania. It's really fascinating. I think there was the dean of UCLA's law school. I can't remember. She wrote a book. She had, I think it was bipolar disorder. And she wrote a book about how it was to experience, just go through, I want to say it's bipolar, not schizophrenia, but I can't remember. No. But it was one of those two diseases, and she talked about kind of her experience with that disease and, professionally being the dean of a law school, the major law school in this country and stuff like that. I'd heard of the book and it's on my list of books to read, but hypomania is such a fascinating thing to me. I feel like what we consider very, like CEOs of companies, things like that, they have like higher degree of symptoms of hypomania. Anyway, okay. So with respect to antidepressants, takeaway from here is you just need to screen patients. So when you ask about depression, ask about mania. And mania can be, what can mania be? Does anybody know? What are like symptoms of mania?
Aggressiveness.
Okay.
Like rush thoughts.
Spraying spree, spending spree.
Spending spree, yes. Yeah.
It's like Spanish breeze.
Spending spree, yeah. So maxing out on their credit cards, right? Like being sexually active with anybody they can find, trying to do crazy physical activities. I don't know, I can't think of one right now. What else?
Wait,
Haven't done this in so long.
this is for hypomania?
So this is for mania. So have you ever had episodes where you just needed, you had kind of like boundless energy and, you needed to do something with that energy, is really how you would ask it. So, yeah. But yeah, spending sprees, patients having unsafe sex, what else?
Professor Slavek, what do you do after you diagnose that, on a patient?
What do you do after you diagnose bipolar disorder?
No, the hypomania.
So you're not going to give them an antidepressant, that's for sure. But you're asking them if they've ever had symptoms of it in their past. They may not have it currently, right? Mm-hmm. What you're going to do is, if you're in psychiatry, you're going to see if they meet criteria for bipolar disorder, and then you're going to treat them with antipsychotics. So you're gonna use another class of drugs.
Okay.
And if you're in primary care, you're gonna make sure they're not suicidal and they're not homicidal, and then you're gonna refer them to a psychiatric facility,
If you-
or psychiatric clinic, sorry.
I kind of like have a person that I need to diagnose and like.
Oh, man.
I just thought about
Like
this
a
trip.
personal thing?
Yeah.
Okay.
It was like,
Try to get them help.
it'll be like 3 a.m. I'll call. He's awake.
Yeah,
Yeah.
okay, so you think, I don't know, you know. So the flip side of mania is depression. So do they go through, that is really the definition of bipolar disorder. Are they going through these episodes of mania and then depression? So these elevated moods where, you know, they kind of have erratic, weird behaviors that you wouldn't normally see. Hypomania can present as somebody who's like, you know, they have 10 papers to do and then they just do them in one night, just like that. You know, they're still productive, but they're like really productive. Yes, and that's why there are, I don't know if there's studies, but there are articles or studies written on people who are like, you know, considered to be extremely successful, CEOs or whatnot, and how there's a higher percentage of them who are diagnosed with bipolar disorder. Bipolar disorder, I think type 2, which is the one with hypomania and depression. Bipolar type 1 is mania and depression, and mania you tend to see the elevated mood causing activities that are harmful to the self, right? So the spending sprees, the unsafe sexual behaviors, things like that. Hypomania though, it's like you can kind of channel the energy. It's kind of but then after that you crash, right? So in the end it's not a great thing. Okay. Okay, so yeah, let's take a break. What time is it? Like 3:30. Okay, we're good.
Bro, she hit every man. Yeah.
Do a little bit more. My voice is starting to go a little bit. Okay. So antipsychotics. So you have first generation and second generation. First generation are referred to as typical antipsychotics. It's kind of a misleading name for them a little bit. I like to think of them really as just first generation. They came first. They have worse side effect profile compared to the second generation, which are called atypicals. Second generations are going to be the kind of go-to drugs for most patients. There's a huge list of first generation antipsychotics. There's really any chemical structure, any drug that had specific chemical structures that was able to treat psychosis was considered a first generation antipsychotic. The two that I would really be aware of, because we still use them, are chlorpromazine and haloperidol or Haldol. And those are the two that I would know, not just for this class, but really for when you start your clinical year, because you may still see them being in use today. And then second generation, I listed the ones there that are the most commonly used, and those are the majority of second generation. For mood stabilizing drugs, we're really just going to talk about lithium. The other mood stabilizing drugs, which I will list in a slide, we'll talk about a lot of them in 2 weeks when we talk about the anti-epileptic or anti-seizure drugs. Okay, so just some definitions. So neuroleptic is a chemical structure or drug that can reduce psychotic symptoms. And you can find psychotic symptoms in lots of different diseases, not just bipolar disorder and schizophrenia. And then what are psychotic symptoms, or what is psychosis? So psychosis can be delusions or false beliefs, hallucinations. Yeah.
I just realized from seeing the other R medication, that's the one I'm right.
The R.
The
Risperidone. That's an antipsychotic, yes. That was the drug that was given to the patient that you were talking about. Okay, not Remeron. Yeah, I know. These drugs can be really confusing. For the vast majority of drugs that we've talked about, the ending is going to give you where that drug is, right? Which drug class it's in, especially for the diabetes drugs, think back to diabetes, and for the psych drugs, okay? Unfortunately, not so much, a little bit for the steroids, I think, right? Zone, I know, a little bit, yeah. So share your lists of drugs, compare to others in your class. Go through the slides. When you're going through the slides, making a list of these drugs as, grouping them into their drug classes, and then looking to see what is that ending, that will really help you remember what drug goes where. Okay, psychosis. So hallucinations and auditory hallucinations. What are auditory hallucinations?
Hearing voices.
Hearing things that aren't there. Visual, seeing things, tactical, even olfactory. But vast majority of hallucinations are going to be auditory, much more than the other senses. Or disorganized thinking in an otherwise healthy patient. Okay. So just let's kind of look at the forest before we delve into some of the trees a little bit. Again, this class is really about knowing the forest, not the trees. So somebody asked me during the break, you know, kind of like, am I going to be asking about individual drugs? Not really. Okay, unless I mentioned it, right? Well, paroxetine, I mentioned it's the only SSRI with anticholinergic side effects to it, right? So that's something to be aware of. But for the most part, the exam is going to be looking at groups of drugs. So I'm not going to ask you about canagliflozin versus another flozin. It's really going to be about all the SGLT2 drugs, right? So remember, just think big picture and be able to recognize which drug is in which class. Okay. So let's talk about kind of the differences between the first generation and the second generation antipsychotics. We said first generation are called typicals. Their side effects tend to be motor and neurologic, so extrapyramidal symptoms and all the stuff that goes with it. They tend to have a high affinity for the D2 receptor, for dopamine receptors. Second generation, your atypicals are going to have more metabolic side effects. So let's pull out our charts. So really this is the one, the selected adverse effects of antipsychotic drugs is the one you're going to want to focus on. The other one that's 6 pages long is for reference. You don't need to memorize which enzyme goes with which drug. Please don't do that. Okay. So looking at your second generation, the first 2 columns are going to be your metabolic columns that you're going to focus on. And you can see there's a lot more pluses in the second generation group, which is at the bottom, right? The second half, than the first generation. So metabolic side effects, weight gain, risk for diabetes, risk for increased cholesterol. These guys have a greater affinity for serotonin, and they also block dopamine, but to a lesser extent. So that right there gives you a clue. What's the cause behind the motor side effects in the first generation? Is there high affinity for dopamine, right? And dopamine has a big role with Parkinson's, right? So that's why these guys are going to cause Parkinsonian-like side effects, EPS, extrapyramidal symptoms. Okay. Because of the way antipsychotics came to be, the drugs actually developed these hypotheses as to why we have diseases like schizophrenia. There's the dopamine hypothesis, there's the serotonin hypothesis. I just want you to be aware of it. I'm not testing you on it, but just be aware of it. It's something that may come up in your next class. Okay, just really briefly, what is schizophrenia? Affects about 1 to 2% of the population. It's characterized by dissociative thinking, impaired logical thought that's not affected by a drug or a disease, right? So there's no other cause for this type of thinking that you can find. There isn't alcohol in the picture. There isn't drug use in the picture. There isn't altered mental consciousness in an elderly patient from infection in the picture, right? So really, these are, in a sense, you have to cross out a bunch of other diagnoses before you can say somebody has schizophrenia. They have the presence of delusions or false beliefs, hallucinations, usually diagnosed in the early 20s. Late teens to mid 20s is kind of the spectrum, but it can be diagnosed at any time. And then a lot of people will argue that schizophrenia and bipolar are diseases of the same spectrum. So let's talk about what bipolar is. Okay, and then before we do that, schizophrenia, they tend to group the symptoms of schizophrenia into positive and negative symptoms. So positive symptoms are behaviors that are gained, and negative symptoms are loss of function. Okay, so that's where the positive and the negative comes in. So your hallucinations are going to be a positive symptom, right? Delusions are going to be a positive symptom. Hyperactivity is going to be a positive symptom. Negative symptoms are going to be low energy, emotional or socially being withdrawn, loss of affect. Yes. No? Okay. Think about it.
Yeah, how's that possible? Oh, because it's gained?
It's like something that's gained, yeah. It's not positive in the sense like it's a good thing. Yeah, unfortunately.
But is it gonna, oh, okay.
So it's something that has added to the person.
But then they have those already?
Yes, they have those. So symptoms of schizophrenia are categorized into kind of
so
positive symptoms. It's bad terminology, but that's the terminology that's being used, unfortunately. Positive symptoms meaning it's in addition to kind of what's normal baseline function. So in addition to normal baseline function, now they have hallucinations, right? So we all have kind of thoughts in our heads, right? Sometimes we talk to ourselves, right? But then you take it one step further and then you have hallucinations, right? Like, I mean, you know, we get what I'm saying. Okay. We're all starting to...
Are you talking to
After this lecture, we're all going to understand. And then negative is a loss of function, right? So you have a loss of energy, you have a loss of affect, your speech now is much slower, your thought processes are slower. The reason why I mention this is because medications tend to be good with the positive symptoms, the things that are in excess. They tend to help treat that better than the negative. So antipsychotics tend to do a lot more for the hallucinations and the psychoses than they do for the low energy or the being socially or emotionally withdrawn from relationships, in your life, or inability to function properly, do your work, go to school, things like that. Okay. But antipsychotics can be combined with antidepressants. So there you go. Okay. So let's talk a little bit of background here. So there are lots of chemical structures that are associated with antipsychotic properties. I mentioned that already. There's lots of chemical subgroups. Posted a little picture here. You don't need to memorize it, but just being aware that chlorpromazine and Haldol are the ones that are most widely used out of the first generation antipsychotics again. Okay, so let's talk a little bit about dopamine. So mechanism of action. These guys, they block the postsynaptic D2 receptors in the brain. And they block all D2 receptors in the brain, not just one particular tract. And that's why we get such a wide array of funky symptoms or side effects from these drugs. So does anybody remember the 4 tracts? Or here they're listed as 3, but yeah, mesolimbic, mesocortical, I heard. Okay, tuberoinfundibular, and the striatal. What's that? I heard somebody say something. I thought that was. I didn't catch all of it.
Is it substantial?
That's part of the striatal, neurostriatal tract. So, okay. So let's talk about them a little bit. So the therapeutic effect is thought to come from the mesocortical mesolimbic tract. If about 60% of these receptors are occupied, is roughly kind of what we think is needed for a therapeutic effect to occur. There's also the chemoreceptor trigger zone. So these guys have strong antiemetic properties. They really help with nausea. The nigrostriatal tract is where you're going to get a lot of the really bad side effects, the EPS symptoms that these drugs can do. If the drug is occupying about 80% of D2 receptors in this tract, then that is what we think roughly correlates with developing extrapyramidal symptoms or side effects, motor side effects, which we'll talk about in a little bit. And then the tuberoinfundibular system is what is basically messing with prolactin and can cause increased prolactin levels in patients who are on antipsychotics. So just from knowing the tracts and knowing that they increase, that they block the D2 receptors in these tracts, you already know what their side effects are, right? So hyperprolactinemia, motor symptoms, and then they also have this anti-nausea effect, which can be beneficial for some patients. Okay. In terms of the first generation pharmacokinetics, their oral absorption can be erratic. Most of them will undergo first pass metabolism, so it just makes their oral bioavailability it's a wide range in terms of these drugs. They're very lipophilic, so we know that because they're lipophilic, they cross the blood-brain barrier and that they distribute widely throughout the body. And they're also highly protein bound. Metabolized by the liver, most have a clearance half-life of 20 to 40 hours. A lot of them have active metabolites, and this actually helps reach stable serum levels in the body. So that's why a lot of them are dosed pretty much one stage. Okay, so let's talk about the extrapyramidal symptoms. Did anybody watch the YouTube video?
Yeah.
Yeah, it's pretty we'll watch a little bit of it right now. So extrapyramidal symptoms refers to a group of symptoms that resemble Parkinson's in some ways. So like I mentioned, they're caused by the D2 receptor blockade in the nigrostriatal pathway. They're much more common in typicals than atypicals. So these should all be reviewed. So what are these symptoms? What do these symptoms look like? So arresting tremor, right? Slurred speech. Has anybody ever seen a patient with Parkinson's?
Yes.
Or have family members? My uncle, he passed away with Parkinson's. So you kind of, once you've seen Parkinson's, you can almost kind of recognize it. Especially if it's a disease that's been in progress for a while in the patient. They can have this akathisia, this restlessness or inability to remain still. They can also have dystonia, which are these involuntary contractions of major muscle groups. So it's like as if they're not able to control, their neck muscles, for example. You may find them like, doing this, for example, in their neck. And then akinesia, which is an inability to initiate movement. So all of these symptoms, you don't need to know, the specific names, but just realize that all of them deal with motor. They, generally speaking, it's, they have restless activities to their motor function. And then it's treated with Parkinsonian drugs. With EPS, it's usually self-limiting, so if you stop the drug, in the vast majority of cases, the symptoms go away. So let me see if I click on this, we can watch it.
We can't see it.
You can't see, what do I do?
You can grab it and drag it over.
Grab it and drag it.
Sorry.
Grab and drag.
Grab and drag.
Oh, what did you do? It's like magic. Thank you. Okay.
That's what he's doing.
So, when did you start having trouble talking?
So you can see his neck, right? It's like this, right? That's the akathisia, slurred
Early
speech.
this morning? And did you take any drugs? Other than your prescribed drugs? No? You don't do cocaine or anything like that?
He's trying to figure out is there something else that could be causing
No.
this.
Okay.
But he's with it. He understands what the practitioner is asking him.
Okay, that's good.
So he's going to give him Benadryl. Look at the difference. It's pretty nuts, right? Okay.
I said what I wanted right now. I feel better.
Okay, we'll stop there. Benadryl. So he'll have to stop the drug. He'll have to stop his, yeah.
Oh, so that was just to stop the reaction.
Yes.
Oh.
Yeah. This is acute dystonic reaction. So one of the EPS, he has a few of them.
Okay. Is that Parkinson's? It's just like,
It's just reaction on the reaction.
okay. Thanks.
Okay. So he had involuntary contraction of his neck, right? Spastic withdrawal calls.
Just those torticles.
Yeah.
We just went with that.
So yeah, so we'll.
It's in Pokemon.
Pokemon?
Yes, you can still treat them as above. Okay, anyway. I had my treatment point up here. That's why I said treat as above. That is the error. Oh, that reminds me. The antidepressant lectures, slide 24. It said anti-ACTH, and that was supposed to be anti-ACH. So take the T out of slide 24. Well, hopefully that. Okay. Talk.
Question, do we need to know what medication?
No, that will treat EPS. No. So, psych will probably, that'll be all psych. Yeah. Just know that these drugs can cause EPS, right? And that you would want to stop the antipsychotic, right? Obviously, you don't want the patient to continue on the drug. Tardive dyskinesia is a type of late onset EPS, so it comes on later after they've started the drug. EPS tends to come on earlier in the treatment. So about after 6 months is when you can see tardive dyskinesia pop up. It's a repetitive jerking movement that can occur in the face, neck, and tongue. And this one is irreversible. So I will watch the video, but I mean, like, I can't imagine living my whole life with this kind of a movement happening. So it's more commonly seen in the typicals, right? So we're still talking about typicals. And in chronic therapy, so long-term therapy, about 5% develop it every year. So 25% at 5 years. And in older patients, it's much higher. Any patient who develops this should be switched to an atypical antipsychotic, and it's usually clozapine or quetiapine. And then you obviously eliminate drugs that have a central anticholinergic effect. So if they're on any other drugs like TCAs or Parkinsonian drugs, and then diazepam can also be given. So again, you don't need to know the treatment, but I put it there just to be more thorough. If I click here, do you think it'll pop up? No? Okay, I have to open it from here.
Yeah.
How do I do this?
Escape, and then hit control, hold control.
Escape? No.
There we go.
Do that?
Is that it?
Oh, yeah, this is it.
Hey.
This repetitive jerky movement in the face, really in the mouth.
Does it ever like stop for them?
Mm-mm. See the tongue?
Extrapyramidal symptoms is the topic, and repeated EPS. And extrapyramidal symptoms are essentially side effects of antipsychotic medications that can occur. And these are commonly tested on the licensing exams. There's 4 types. And I'll try to
Maybe
go
they're put,
through
I don't know, to tell the truth. Maybe they're put on a diet that's more purine, right? Yeah, so
So the first of the 4 types.
sure. I don't know how to stop myself.
It's like there's a few others
Just putting
open.
on my,
It's the
Like you see
second-
the tabs.
because I clicked on it so much.
Yeah.
Okay.
Boom.
It's on the other screen.
What do you mean it's on the other screen? I can't see my arrow. Why is this so confusing to me?
It's usually easier to see when it's like next to each other, so but it's like instead it's like.
Yeah, okay. Yeah, there are 2 different screens. Okay, thank you. Okay, so yeah, so this is something that you obviously constantly want to be screening for. You want to tell patients about so they know, and that they come to you to stop the medication. Okay. I've never seen this. Has anybody ever seen this? I don't. You have?
Nursing
Were you
homes.
working in there?
I worked with a lot of elderly. I used to be an ophthalmic clinician,
Okay.
and so my doctor did glaucoma surgery and cataract surgery, and most of our patients were older patients.
And some of them had psychiatric conditions. Is that why, like, they had been on?
I could, well, like, just seeing that they had, like, repetitive movements like that. And I never knew what it was.
In the mouth and
Yeah,
the tongue?
Mm-hmm. Like, movements over here.
Do you know how they ate? Somebody had a question. I don't know.
No, I think.
No.
Yeah.
But,
I don't know. I've never seen it. Maybe, I don't know. It was in a nursing home, so.
To say to that, is that a common thing? Because I think I've seen that in elderly people. I don't think they
So,
necessarily have
a resting tremor is very common, but usually in the hand. Yeah, not in the face. I mean, some people have like twitching, right? But it's nothing like this. Yeah. I've never ever seen this ever. Just YouTube. Hopefully I will never see it. I don't, hopefully all my patients will never experience some teaching this, and all of your patients do. Yeah, I can't imagine what it feels like to live with it. I mean, right? Like, my concern for suicide for that patient was like sky high, so sky high. Okay. Neuroleptic malignant syndrome, also kind of on that continuum of severe side effects with these drugs. So this is a life-threatening disorder of thermoregulation and motor control. Mortality rate can be 21% if it's not treated. Tends to occur in patients who are extra sensitive to the EPS effects of antipsychotics. Who knows what their underlying physiology is with respect to their dopamine tracks in their brain? Who knows? But it's characterized by fever and severe muscle rigidity. Those are kind of the two big things. They are not able to sweat because of the anticholinergic effects of these drugs, so that then they develop high fever. There's mental status changes that comes with it, and this autonomic instability where their blood pressure is going up and down. And these guys are in the hospital to be treated. After they're treated, then they're switched to an atypical.
Well, how does that one come about?
So it's thought that these patients who, for some reason, have an underlying susceptibility to the extrapyramidal symptoms of antipsychotics, and what that translates to in reality, like why is their dopamine tracks more sensitive? Is it maybe the way they metabolize these drugs? No, I don't know. Is it the type of receptor, D2 receptor that they have, like the gene allele? I don't know. I don't think it's known why this really happened. I mean, the stuff that I just said is things that I'm coming up with, right? Like potentially why, I have no idea. And I'm not sure what the literature says, but what I do know is that typicals really aren't used that much anymore. We try to use the atypicals. So, and that's probably why I haven't seen these kinds of things come up. Okay, so just to kind of recap a little bit on first generation. So you can also, so let's pull out this, which is the selected adverse effects of antipsychotic drugs. Okay. So we can break down first generations into high potency and low potency. And what I mean by that are drugs that have a high affinity for binding to D2 receptors, and then drugs that have a low affinity for binding D2 receptors. So chlorpromazine and thioridazine are the two. What I did, you can copy me if you like, is I put a little L by them to let me know that that's low potency, and the rest I put H. And then you can kind of see the pattern of side effects. The chlorpromazine and thioridazine kind of tend to follow each other a little bit in terms of their side effect profiles, and the other ones also, their side effect profiles are grouped. So let's talk about what that means. So in terms of doses, first of all, the high potency are obviously going to be dosed at a lower dose, and the low potency are going to be dosed at a higher dose. That makes sense, right? So you want to get a therapeutic effect, and to get a therapeutic effect with a high potency drug, you're not going to need as much of it. With a low potency drug, you're going to need obviously a lot more. The high potency drugs have low histaminic and muscarinic activity. So let's look at our side effect chart, right? So we're talking about high potency drugs. So you can see, for example, under sedation, right, and anticholinergic side effects. the two low potency drugs are the ones that have high histaminic and muscarinic activity, right? So they're going to be high sedation, high anticholinergic side effects. Do you guys see that?
Yeah.
And then the rest are all high potency, and they're going to have lower sedating and anticholinergic side effects. Lower weight gain, but the high potency have a higher risk of EPS. That makes sense, right? They're binding to the D2 receptors a lot more, and so the risk of causing EPS symptoms are going to be a lot more. Low potency are the opposite, okay? So I really like this slide. I think if out of any of the slides you review for antipsychotics, review this one to know the first generation, okay? And review it in conjunction with your table if you're a person who likes to look at tables. And you'll have a really good grasp of what the first generation antipsychotics do, what their mechanism of action is, and then their side effect profile based on which receptors they inhibit or interfere with. Okay. The next few slides, I put a little bit more detail about chlorpromazine and Haldol. I'm not gonna spend time on them. They're there for you guys to review because you may see them being used when you start clinicals. These two are so wordy, but basically what I did with the next slide on chlorpromazine was I listed all the receptors and then the side effects. So again, if you want to review, alpha-adrenergic, orthostatic hypotension, it's just another way to review those receptors, the blockades of which receptors and their corresponding side effects. Haldol, same thing. The one point I want to make with Haldol is there's a depot formulation of this. Does anybody know what that means? Depot formulation. Okay, so, or depot. You've heard depot.
Isn't it that shot?
Yeah, so depot is usually an intramuscular shot, and it's not just birth control. So there's a depot formulation of progesterone, which is the birth control contraceptive that you guys will learn about soon. That can also be given. Depot is a formulation of a drug that can be given intramuscularly, and you give it one time and it can last for a long time in the body, right? So if you're familiar with the depot shot, which is progesterone, that can last 3 months or so. The contraceptive effect of it can last 3 months. Haldol, there's a depot formulation of Haldol. Why would you give a depot formulation of Haldol? Yeah. Or a patient who has a really hard time taking pills, right? They can come in, get a shot once a month, and that's their maintenance therapy, right? A shot once a month, that's a lot. Time it with their appointment and they're good to go. So it can be a really nice way to treat patients.
Is it more expensive?
The Haldol depot is not expensive, I think, anymore. Yeah, it's been used for so long. So, okay. So let's talk about second generation. Second generation, in terms of their clinical efficacy, they seem to be pretty similar to first generation, except for clozapine. So let's pull out our little thing again. We won't really talk about side effects right now, but I would put a little star by clozapine because a lot of times clozapine is used, it is saved kind of in the back pocket of clinicians for treatment-resistant schizophrenia. So they'll go to it when they really, really need it. It's a very powerful antipsychotic, and it has some interesting side effects that we'll talk about. The big one being agranulocytosis. So that's really why it's not a first line drug, plus the metabolic side effects as well. But it is used as like a last resort type of drug. So. In general, though, the second generation are considered to be less toxic, right? They don't cause EPS, extrapyramidal symptoms, TD, tardive dyskinesia. I just put in there that paliperidone is a metabolite of risperidone. Again, I like to mark up my charts so I have everything in one thing. So, whatever you'd like to do to help you remember. Okay. So they also block postsynaptic D2 receptors in the brain. There are some, I put a few exceptions in there. You can read about them a little bit more. But unlike first generation, they have a higher affinity for serotonin than they do for dopamine, okay? So that's why they're not really causing the EPS symptoms. This higher affinity for serotonin led to the serotonin hypothesis with regards to schizophrenia. So we have all these hypotheses about schizophrenia, but we don't know what really causes it. Okay, and then they also have affinities for other receptors, and you can kind of guess based on their side effect profiles, histamine, anticholinergics, what they may interact with.
I have a quick question. So
Yeah.
For the chlorpromazine, under the indications, you wrote that it's used for sedation. How is that possible if the side effect of the drug is sedation?
The side effect of chlorpromazine can sometimes be taken advantage of and used to sedate a patient if needed.
Oh, not for treatment of sedation.
No, not for treatment of sedation, but used to sedate a patient. Yeah. So maybe make a note if my wording is not too clear on the slide. Which slide number is that? 15. Okay, yeah, under indications, to sedate. Yeah. Slide 15. There's an indications note for chlorpromazine, and chlorpromazine is very sedating. Yeah, so sometimes it can be used to sedate a patient, basically.
Just one more question.
Yeah.
What causes the agranulocytosis?
I don't think that's no.
Oh no, because
What causes it?
Yeah, which drug were you speaking of?
Oh, which drug is clozapine?
Okay.
Yeah, but what causes it? I don't know if that's why that particular drug can cause agranulocytosis. It doesn't do it in every patient, but it can. There's a risk of it. Yeah.
Okay.
So you would monitor patients with CBCs who are on clozapine. Okay. So additional receptors that atypicals can affect are muscarinic, alpha adrenergic, histaminic receptors, right? So we already know what those side effects are because of TCAs, right? We covered all this with TCAs. So, okay. Again, kind of the theme in psychopharmacology, their absorption and bioavailability really differ between these drugs. They are easily absorbed, but not completely, and a lot of them undergo this first-pass metabolism. They're lipid soluble again, right? Like all psychopharmacology drugs that we want them to get into the central nervous system. They're highly protein bound. They distribute largely throughout the body. Okay. In terms of the duration of action, so they have long half-lives. So once daily dosing is common, again, for most of these drugs. Their duration of action is longer than you would estimate by their half-life. So active metabolites may be at work there. And then average time to relapse after stopping the drug is 6 months out. So these are going to be in the system for a while in patients after they stop them. Except for clozapine. Clozapine, you have to taper off that drug. So they can relapse really quickly after stopping clozapine, and you want to taper off of it so they don't have kind of like a withdrawal effect from it. Okay, so these drugs are going to be metabolized by the liver. Except for paliperidone, is primarily the kidney, right? So, so what would be a good drug in liver disease? Paliperidone, exactly. Okay. And then in terms of administration, we have the depot, which we just talked about. There's orally disintegrating tablets, which, tablets that you put on the tongue and they just dissolve right away, don't need to be swallowed. And then there's immediate release that are in forms of an injection, which can be used in emergency situations. These are besides just your regular once-a-day pill form. Yeah.
So you said the risperidone is metabolized to paliperidone?
Paliperidone is the active metabolite of risperidone. Yes, so risperidone is metabolized to paliperidone. So is risperidone, so risperidone is metabolized to paliperidone, and then paliperidone is removed via the kidney. Is that, so you wouldn't want to give risperidone to a liver patient, but you can give paliperidone to a liver patient.
So do you also have paliperidone as a medication?
Yes.
As such? Okay.
Yeah. Yeah, so it's interesting, I don't know where this came about, but you find this as a common theme, and is it because, when they're like making these drugs, they're like, okay, well what about patients who have renal disease, or patients who have liver disease? So then, let's make the active metabolite also a drug. Okay. So I put a whole bunch of clinical indications here. We talked about schizophrenia and bipolar disorder. You can use antipsychotics to treat depression, actually, as adjuncts to antidepressants. I've never seen that being done, but it is possible, and it's something that psychiatrists will sometimes do. Tourette's syndrome. Does anybody know what Tourette's is?
Yeah.
Tics, yeah? Okay. Alzheimer's disease, Parkinson's disease have components of dementia and psychosis, so antipsychotics can be used there. They can be used as antiemetics. Prochlorperazine is an antiemetic, Reglan. And then for anesthesia, which we actually just talked about right now, relief of itching. I've never seen an antipsychotic used to relieve itching, but it's listed as an indication. Okay. We talked about adverse effects. So I feel like we've beaten this horse down. Okay. So let's pull out our table. So I want you guys to tell me which drugs have the highest risk of metabolic side effects. Clozapine and olanzapine. So which patients we talked about clozapine, so what about olanzapine? Which patient would you avoid using olanzapine? Patients with diabetes, high cholesterol, heart disease, right? Okay. So let's see. And then which one, so you have a patient with diabetes. What drug from the second generation would you want to give? Or a few drugs.
Aripiprazole.
Aripiprazole, yes. That would be that one, or which one?
What about pimavanserin?
Yeah. Cariprazine? Yeah. Yes. Right? So basically, you guys understand the graph. Yeah, none of us know how to say these drugs, including myself. So yes. So okay. So let's move on. Let's look at anticholinergic side effects. Which one's the worst? Clozapine. Yes. And then you have a bunch that don't have as much anticholinergic side effects, right? Which one's worse with orthostatic hypotension?
Clozapine.
So now you can see why clozapine is reserved for treatment refractory disease, right? It has a lot more side effects going on than the others. Okay. A word on this. So patients that get put on drugs that have a higher risk of metabolic disease or metabolic side effects, how are you going to monitor them? For metabolic, you're going to want to check what?
Sugar.
You're going to want to check sugars. You're going cholesterol. Exactly. Yes. With the one that has orthostatic hypotension, you will want to check their blood pressure, right? And have an idea. Okay. So hopefully these tables don't look so scary anymore, right? Yeah. So you can see there are trends. Yeah.
Are these side effects common?
The metabolic side effects are really common. Yeah. Unfortunately, that's what the second generations are known for. Are known for their metabolic side effects. Yeah. Okay. And then the anticholinergic side effects, if they do occur with drugs, tend to be usually the most common side effect if it occurs in that drug. Yeah. Okay. I listed a bunch of others. So let's talk about cardiac. Let's see. So QTC prolongation. Which one are you worried about with QTC prolongation?
Ziprasidone.
Ziprasidone and iloperidone. Right? So with those drugs, you may want to get a baseline EKG, right? Just so you have one on hand. You're probably not going to use that type of a drug in a patient who has some sort of cardiac disease. In terms of pregnancy, the goal is to not be on an antipsychotic. I don't know a lot about treatment of psychiatric conditions in pregnancy. That's a really tricky subject. But the goal is that they're not on antipsychotics and they're monitored really closely. Pregnancy is interesting. Patients will report a lot of times that their disease seems to quiesce during pregnancy. It's a weird phenomenon, and you see it in a lot of diseases, not just psychiatry. Okay. So antipsychotics have a black box warning too. Okay, so elderly patients who have dementia-related psychosis who are treated with antipsychotic drugs are at increased risk of death. These patients, unfortunately, are baseline at increased risk of death, right? I mean, these are patients who have diseases that are end-of-life diseases for the most part. It's not really clear in the studies if the drug actually has any role in that or not, or if it's just that maybe these patients at baseline are sick, a group of patients who are much more sick. And so it's not clear that it's really the antipsychotic, but that black box warning is there. In terms of overdosing on antipsychotics, they're rarely fatal. Okay, so we're not as scared as we are with TCAs, except for with two, thioridazine and mesoridazine, which are second generation? First, yes. So in terms of symptoms, they can start off with being just drowsy, lethargic, and then end up in a coma, essentially. Okay. So just be aware that you can overdose on antipsychotics, but they're rarely fatal. The two that can be fatal because they affect the heart are mesoridazine and thioridazine. Okay. We talked a lot about, I feel like, scheduling and dosing. Okay, a takeaway from here is that you can combine these drugs with others, with SSRIs, with lithium, with benzodiazepines. So you can see patients are on multiple drugs. Again, when patients are going to be using a combination of psychiatric drugs, what are you going to do? What's that? You're going to check for interactions, yeah, with any other drug that they're on. So we talked about choosing based on kind of side effect. We've mentioned cost. The vast majority of patients have schizophrenia. Typical versus atypical really will have equal efficacy, but we talked about why atypicals are favored. And then I mentioned a few, like 2 examples. We kind of went through this with the table, so we don't need to talk about that. Again, here I kind of picked a few and just put a lot more detail. If you want to go through them, you can. So you can see kind of the complexity of these drugs in terms of their mechanism of action, right? I'm not going to test you on do they, block histamine, H1 more than 5-HT2A. I don't think that's worthwhile knowledge to have. I think better to know that these drugs, again, have a wide range of side effects because they have a wide range of mechanisms of action that affect these neurotransmitter systems, right? So they affect dopamine, they affect acetylcholine, they affect histamine or serotonin. Let's see. Clozapine, I think I mentioned most of the takeaways with clozapine. So agranulocytosis, I mentioned it, but again, just to hit that point home, they need CBCs before treatment, and then afterwards they do it weekly for about 6 months. And then after that they go to bi-weekly and then monthly. So you're really monitoring them really closely. Okay, so let's quickly talk about lithium, and then we'll be done. And then either we can go straight into questions, or we can take a little break and go into questions. So, so here I put a little bit about bipolar. Bipolar can occur in childhood, but most patients are diagnosed in their 30s or 40s, and we talked about kind of the mania, hypomania, and depression phases. So manic phase, so this expansive, irritable mood, impulsive behaviors. They have less need for sleep, racing thoughts. We kind of talked about how what kind of behaviors that can show up in. We talked about how depression is the phase that patients will spend the majority of time that they're in. Bipolar disorder has a really high risk of suicide. Which phase, manic or depressed?
Manic, right?
Manic, big time, yeah. Depressed too, right? Yeah, but manic especially. So manic, the best way I would characterize it is the person thinks they can do a lot more than they're really physically capable of doing. Okay. So this is a list of drugs that can stabilize mood. We're only going to talk about lithium. We already talked about antipsychotics, and then anticonvulsants or anti-epileptic, anti-seizure drugs we'll talk about in 2 weeks. So lithium is an element, obviously in the periodic table. It was shown to be useful for the manic phase in 1949. It doesn't have a use in schizophrenia, just in bipolar really. Sometimes it'll be used in depression. I again never seen it, only heard of it. And in terms of bipolar disorder, it can be used for both acute phase and then maintenance or prevention. Okay, its mechanism of action is really not well understood. There's a lot of theories out there as to how it works. What we do know is that it affects like every single neurotransmitter system in the body. So it stimulates inhibitory neurotransmission and it inhibits excitatory neurotransmission. And it may have a neuroprotective effect actually in these patients. Okay, so it's rapidly absorbed. Food doesn't alter its absorption. Again, a great point I feel like in psychiatry in these drugs. The peak serum levels will occur in about 1 to 2 hours with immediate release, and then 4 to 5 hours with slow release preparations. That's what prep is. It's not protein bound, so it's one of the few psych drugs that is not protein bound, right? And so its volume of distribution is approximately that of total body water. It's not metabolized, it's excreted primarily in the urine. So in renal disease, does it need dosing adjustment? Yes or no? Yes, exactly. Yeah. So its elimination is really determined by renal function. So as patients age, they will be less efficient at eliminating lithium from the body. So I listed some of its indications and contraindications, renal disease being one of them. Let's see, drug interactions. So drugs can interfere with its clearance by the kidneys. So diuretics and NSAIDs can reduce its clearance by 25% and can increase the risk of lithium toxicity, right? Lithium is a drug that when a patient is started on, they will be monitored with serum checks, lithium levels, to make sure that the level of drugs in their serum is where you want it to be. Because lithium is a patient can easily reach toxic levels of lithium on what you think may be a therapeutic dose. And that is because there's a lot going on to affect its clearance. And then another takeaway here is that except for clozapine and the atypicals, the first generation antipsychotics, when they're combined with lithium, the risk of EPS goes up. Okay. In terms of its renal, so it can have a lot of renal side effects. So again, a big takeaway, this is a very common board question with lithium, is what kind of renal effects, toxicity effects can it have? One of them is nephrogenic diabetes insipidus, DI. Does anybody know or can think of a way that lithium would cause DI?
All in the dehydrated states.
Yeah, that's the next slide. That's the next slide, the next slide. So ADH, what does ADH do?
It takes water back.
Mm-hmm.
Retains water.
Yes. So lithium essentially interferes with the ability of ADH to reabsorb water back in, right? So lithium can cause polyuria and polydipsia. What is polyuria and polydipsia?
Or you're
Excessive urination.
Yeah,
Excessive
lots of
thirst.
urine, lots of thirst, exactly. This can be irreversible, okay? So again, something to be aware of. So the treatment is usually you discontinue it, and there are some drugs that can be used to help. Amiloride is one, but just know that there are sometimes drugs to help treat this, obviously. Nocturia, which is using the bathroom at night, right? Urination at nighttime can be a clue that this is happening. But the biggest thing is you'd want to stop the lithium. Lithium can also just cause a decrease in renal function that can also be permanent and sometimes could end in end-stage renal disease, so meaning the patient would need to be on dialysis. And then the interactions of lithium with kidney function can also result in hyperparathyroidism, so increased PTH, increased calcium, and a lower calcium in the urine. Okay. Lithium can also have effects on the thyroid. So think back to the last lecture. So it can increase intrathyroidal iodine content, which can inhibit coupling and release of thyroid hormone. So with patients who are on lithium, you're going to not only be monitoring the renal function, you're going to monitor their thyroid as well. And then it has a whole host of other things that it can cause. One that I would be aware of is that during pregnancy, it can cause Epstein's anomaly, which is an anomaly with the heart. And that's why we avoid it, especially in the first trimester of pregnancy, because that's when cardiac development is occurring in the fetus. So I mentioned we're monitoring serum lithium levels. So this is the slide you were referring to. So things that can cause higher serum lithium levels would be things like
Dehydration.
yes, dehydration, decreased sodium intake will cause higher levels of lithium, and then the opposite will cause lower levels. Okay, last slide. Yay. Okay. So you mentioned toxicity is closely related to serum lithium levels, which is why we monitor it so closely. Toxicity can cause seizures and circulatory collapse. It's pretty severe. And lithium, really, takeaway from here is that lithium has a really narrow therapeutic index. So what does that mean?
It can become therapeutic.
Dose for you to give to achieve a therapeutic range and for you to achieve a toxic range is very narrow.
Exactly, yes, yeah. So that's why we measure it. And I put down kind of how we measure it, again, just for your information. Okay, so that's like a lot of information, I know. So do you guys want to take a minute or two, and then if you have questions, I'm happy to answer them, or do you just want to jump into questions? Jump into questions. It's 4:39, so that's not bad, right? You're good. That's pretty good. Okay. And if you have no questions, you want to leave, you're welcome to leave. You do not have to stay. So I kind of talked to you guys already about the exam, and I really have nothing else to add, but just, yeah.
I'm a little confused between AIT1 and AIT2.
Okay, so let's pull up that slide. So everybody pull up AIT1 and AIT2.
You want it on the
You guys want me to pull up the slides on here, or do you guys?
Yeah.
Yes? Okay. Oh, that's the one. You're welcome. talking about this right here, right?
Yes.
Okay, so let's kind of walk through it. So AIT stands for amiodarone-induced thyrotoxicosis. So let's break that down. So that's amiodarone causing harm to the thyroid, right? Toxicity to the thyroid. AIT 1 and 2 is just referring to the fact that AIT 1 are patients who have underlying thyroid disease. So that will give you a clue as to the mechanism of how this is happening. AIT 2 are patients who do not have underlying thyroid disease. Okay? So AIT 1 is a true iodine-induced hyperthyroidism. Okay, so you have increased synthesis of thyroid hormones because of excess iodine. Remember, amiodarone has a lot of what?
Iodine.
Exactly. Has very high iodine content. Okay, so patients who have underlying thyroid disease, and then you give them this huge iodine load from amiodarone, are at increased risk of having hyperthyroidism. AIT2 is basically the drug is destroying thyroid tissue. And so what happens is you get this excessive release of thyroid hormone initially, so they're hyperthyroid, and then they go hypothyroid after they've released all the thyroid hormone that they have, or a great chunk of it. Yeah. So they have a hyperthyroid phase that can last weeks to months, followed by hypothyroid phase, then they're euthyroid, so they're normal. Yes?
These happen to patients who are being treated arrhythmias?
Yes, amiodarone is usually given for cardiac. Yeah, it's an antiarrhythmic agent. Yeah. So it's not given in this, but it has such a high, I think it's 20% of patients who take amiodarone will end up with some kind of thyroid dysfunction. So you must know this for patients, not just for boards, but for patients who are on amiodarone. You'll need to monitor them for thyroid dysfunction. Yeah.
So, because you said the AIT2 is the
AIT2 are the ones who don't have underlying thyroid disease, and the amiodarone is basically just destroying thyroid tissue. And so when it destroys thyroid tissue, initially thyroid gland will release a lot of thyroid hormone, so they're hyperthyroid. And then after the thyroid gland has, after it's been released, then they become hypothyroid. Then the thyroid gland will, it's time for it to kind of, resolve itself. And then if they become euthyroid, it can. And I wouldn't get hung up on the details of AIT1 and 2.
Okay.
Yeah. But know that this can happen, right? So, yes.
On slide 27.
Of this lecture?
Yeah.
Thyroid? Okay, yeah. This is mostly here for you to just know and be aware.
Actually, it might be 28 for you. I don't know why it says 27. All right, never mind. 26 for you.
The numbers is below.
Oh, okay, the numbers are below.
Yeah.
Oh, okay,
Thank you.
that makes sense.
I'm to my
All right, so you see where it says inductions / reduction of the TPG. So I'm just trying to make sense of this because, like, when I was reading the notes down there, it said that if you're pregnant, have estrogen, or take oral contraceptives, there's a shift of the hormone from free to bound. And
why is there a shift from hormone from free to bound? Because there's a
increased TPG. So.
Yeah, induction of thyroid binding globulin. Yes.
So that can induce hypothyroidism, hypo.
So that's an interesting question. I had a friend once who was almost diagnosed with a thyroid disease during pregnancy because of this very reason. She had no problems with her thyroid hormone, but at the time of testing, it was, I really think, during that shift, right? And so,
what causes the shift?
Estrogen. So estrogen, for some reason, causes the body to produce more thyroid binding globulin. Thyroid binding globulin is the protein in the serum that binds thyroid hormone. And bound thyroid hormone is not active, right? It's only the free that's active. Yeah. But in a normal euthyroid patient, the body will compensate, right? So even though the free shifts to bound state, the thyroid hormone will just amp up and then produce more thyroid hormone to get it into that narrow free range that it wants it in, and then it's done.
Right.
So if you have a patient, the point that I'm trying to make here, okay, is if you have a patient who's hypothyroid,
what are you gonna, you're giving them now their free thyroid hormone, right? You're giving it to them in a pill. What are you gonna need to do during pregnancy for most patients who have hypothyroid and they're pregnant? You're gonna increase their dose. Does that make sense?
Yes.
Yeah, right? Because you have now more binding globulin in the serum. You have more of that protein that binds thyroid hormone. So the body produces a lot of binding globulins for thyroid, for cortisol, right? And the reason why it does this is because hormones are very active, right? It needs a way to be able to regulate and say, hey, I only need this much hormone right now at this site, this instant, right? I mean, our bodies work like that. They're instantaneous. And binding globulins are one way that they have a readily available supply of hormones that the body, that whatever organ needs to use at any instant can use. And it's just another built-in regulatory mechanism by the body to be able to very sensitively adjust hormone levels. Does that make sense?
That makes sense.
Okay.
And like, say somebody's taking oral contraceptives, so like, because for the euthyroid, everything's just like beautiful.
Yeah, so in a euthyroid patient, you have a gland that's able to respond to these changes easily. But in a patient who has a gland that's diseased for some reason, it's not going to be able to do that same response. It's not going to have that same response. And so if whatever medication you're giving, you're the gland, right? You're essentially saying, oh, they're in a state of increased need of thyroid hormone or a state of decreased need of thyroid hormone. And so you're going to increase or decrease as needed. These are the vast majority, especially for hypothyroid patients, this rarely happens. So say you have a patient who has hypothyroidism and they're on Synthroid and then you start a birth control pill. What I would do is first I would just check a TSH a few weeks after they've started their birth control pill, and I would monitor them a little bit closer, and if their TSH isn't at where I want it to be, then I would increase their thyroid hormone appropriately. Yeah.
For your friend, you were saying that she got pregnant, so
she was pregnant, and then she developed symptoms, and I don't remember details, but initially her OB thought she had some kind of thyroid disease, and then endocrine saw her and was like, no, this is all related to pregnancy, and it was because of this kind of shift in the body.
So in the pregnant patient, would you wait?
Yeah, so pregnancy and thyroid disease can be really tricky. It can be really hard to diagnose thyroid disease during a state of pregnancy. Like, was somebody maybe subclinical and then something popped up during a pregnancy? So me personally, where I don't really do OB, I would get the help of endocrine to help me figure that out, for most of these patients. Yeah. Especially if you're looking at hyperthyroid. I think hypothyroid is a little easier to see. No, she wasn't treated, yeah. So the endocrine, I think they repeated.
Additional symptoms. So like your thyroid gets larger when you're pregnant, but that doesn't necessarily mean you have hyperthyroidism.
Yes.
So you look for other symptoms. If you go back to like we did it in section. Yeah.
Great. That's a great answer right there. Mine? Yeah. Family medicine. Yeah. But I do primarily adult medicine. Any other questions? No. And I think it was hyperthyroid that they thought she had. I can't remember details.
Yeah, they were saying like naturally, like the thyroid can be enlarged with
pregnancy.
So like it is difficult to like a lot of people want to automatically jump to the conclusion
when they palpate the thyroid gland.
But they said there was like I can't remember specifically what symptoms, but they said typically with hyperthyroidism there's some other symptoms that you look for in addition to an enlarged thyroid gland.
Yes. So pregnancy itself, you can have symptoms. You can have symptoms of hypothyroid, right? Pregnant patients get constipated, their GI tract slows down. Yeah. But you can also get symptoms of hyperthyroid where they're kind of more anxious and jittery and whatnot. So yeah. For my friend, it was all labs, and I can't remember details. She didn't send me labs. She just told me they think I have a thyroid disease. And then I said, which one? Do they think you're high or low? I think she said high. And I was like, okay. Which makes sense based on what you're saying. But then the endocrinologist repeated her labs a few weeks later and was like, you're fine. Just this is pregnancy-related changes. This has nothing to do with any kind of
I
therapy.
think that's kind of what we do, is kind of
That would be on Exemplify.
Yeah, whatever method you guys take to examine it. Yeah, that's the method that you will take.
How many questions?
I have probably between 50, 60 questions, about 20 questions a month. Maybe 20 questions a week. What's that?
We can email you.
You're welcome to email me. I'll hang out here for a little bit. So yeah, if you guys have any questions, please don't, like, you guys will all be fine with this exam. It's not a difficult exam. It's really just, unfortunately, we test retention of information. This kind of testing, I know. So you gotta know something, right? Yeah.
Thank you, Professor.
See you guys later.
So in the terms